Good evening all to the 132nd session of the weekly huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We both are cardiologists working at KIMS Hospital. Today's discussion is a little bit very basic, but at the same time, I brought up this case because it highlights a lot of very practical clinical decision making, which we pretty much take it for granted. I don't think there is any textbook explanation of what we do. And even then, we all pretty much end up practicing in a similar fashion, which sounds intuitively correct, but I'm pretty sure a lot of us never actually thought very deeply about it. I'm talking about how to adjust the thyroid supplement or the thyroxine supplementation that we pretty much give to patients who have a diagnosed hypothyroid, and how to further work on that. So this is a case, it has a complex cardiac history. I'll just very briefly mention it, and then we'll focus mostly on the thyroid aspect of it. So he's a 52-year-old male, almost about 3 years now, 2.5, 3 years back. He was admitted with anterior wall MI. At that time, he was 49 years old, didn't have any known comorbidities at that time. So it was an extensive anterior wall MI. He presented on VT storm. He was taken up for primary PCI, which was done in a very short duration. He had a prolonged course, but he subsequently recovered from it without any problem. And his LV actually improved back to normal, about 55 to 60%. Because of his recurrent VT, he did get an ICD during that time. So that was around 2.5, 3 years. During that admission, he was also diagnosed to be hypothyroid. His TSH was on the higher side, and T3, T4 being on the lower side. So at that time, because of this arrhythmia and whatnot, he was initially started on very low dose of thyroid supplement. And later on, over the next few months, it was titrated up to 100 micrograms daily. And for the past 2 years or so, he had been quite stabilized with that 100 micrograms daily of thyroid supplement. And his TSH and rest of the profile have pretty much been in normal limits. So that was the entire story. He was on usual cardiac medications post-discharge, but he was also put on amiodarone as an antiarrhythmic therapy for his VT. And because he had an ICD, we had continued interrogation on the device. And after about 9 to 12 months or so, when there was no further recurrence of VT, his amiodarone was stopped. And at any given time, he was not taking more than 200 milligrams per day of amiodarone. And he has taken it for about, I would say, maybe 10, 11 months or so. So from that time till now, he had been off any antiarrhythmics. His LV has recovered, and he's on usual cardiac medications and with 100 micrograms of thyroid supplementation. Now, he came to my OPD just a few days back, and at that time, it was a routine visit for him. But he complained that he had been jittery for the past 1 month or so. He has lost 2-3 kilograms of weight. And also, he has recently noticed a rise in his blood pressure and pulse rate, which so far have been very stable. His blood pressure at times is rising up to 190, 200 systolic. On examination, he's quite anxious. He's kind of fidgety in the room, which is not usual for him. He has got slight distal tremors. His heart rate in the OPD was 92, blood pressure was 178, diastolic was close to 100. The rest of the exam was fine. We did investigate, and most of the labs were okay, except thyroid profile, which I have mentioned. His TSH is undetectable, so less than 0.01. Total T3 and T4, they both are elevated, with T4 being 23 and T3 being 280. So they both are reasonably elevated from the baseline. His ECG and echo is normal, and we did ICD interrogation, and that was also okay, with no signs of arrhythmia, and all the parameters were stable. His active medications are what you would expect for a patient like him. He's on dual antiplatelet with a statin. He's on a reasonable dose of carvedilol, ACE inhibitors, and some lifestyle medication like PPI and multivitamin as and when required. He's not taking it on a daily basis. So basically, when a patient like these come to us, where these are diagnosed hypothyroid, who are taking thyroid supplementation, and now they are exhibiting hyperthyroid kind of features. Now, this patient didn't have any thyrotoxic storm, as to speak, but he did have all the features of hyperthyroidism. And with the thyroid profile, it was quite obvious that his thyroid numbers are all up. So what do we typically do? How do we typically approach to these patients with such kind of deranged thyroid profile? First of all, uh, is it iatrogenic, which is thyroid supplement induced, or is there any other differential diagnosis? How do we typically approach these cases? Should we reduce the supplement dosing and see how the thyroid profile behaves or how the symptoms behave? How much should we do the dose adjustment? Is it arbitrary, as in you just go to one lower dose available, or is it tailored to what the TSH and rest of the thyroid profile shows? Is there a certain algorithm that we should be practicing, that with this much of quantum difference, we should be reducing or increasing supplementation by this much? Or in this kind of situation, should we simply take an approach of stop and go, where you stop the drug, let the thyroid levels come up slightly, and then restart at a lower dose? Some of it could be equated to what we do in our warfarin setup, where we kind of make dose adjustments based upon INR, but there a lot of dose adjustment is based upon the absolute value of INR. So is it something similar over here, where the thyroid profile levels should dictate how much we should be changing the doses for us? And in this kind of situation, are there any additional treatment options that we should be looking at based upon what differential diagnosis we are talking? So I'll start with Praneeth as a customer of this huddle discussion. Praneeth, if this case was to come to you, his cardiac parameter seems to be reasonably stable, except recently where his blood pressure and pulse rate are both going slightly higher than what they were, but rest of the parameters are okay. His thyroid profiles are obviously deranged, but he's taking this supplementation. So walk us through what is your thought process, and then we will ask other attendees for their impression. And I have Brinda joining us, who is an endocrinologist, who can walk us through her expert guidance about cases like this. So Praneeth, all yours.
Yeah, good evening, everyone. So this patient, firstly, I would be surprised to note that patient who was otherwise well managed or well controlled thyroid status, he is having a deranged thyroid parameters in hyperthyroid state from being hypo, which is well controlled. I would be surprised and equally a bit concerning because of his cardiac issue. Thyroid being a symptomimetic agent, and this hyperthyroidism can induce arrhythmias, particularly when this patient is having this VT and all. I would be definitely concerned. So controlling this hyperthyroid situation will be a bit of priority for me, because I do not want him to have uneven this change in course from what he's been having a stable course for the last 3 years. First thing, I would think that it is probably iatrogenic, where if he has mistimed his drugs or he took double doses and all, that could be the reason. But having said that, having that high level definitely looks like it's almost kind of like unless somebody takes too many pills, it's an issue. If you are taking one or two or once or twice, it should not be a problem. So though I the first thought that comes into my mind is that it's probably iatrogenic, where he was taking more than what he's advised to. But I still doubt that it is not possible unless you are taking it having some dementia or you are having some suicidal tendency, etc. So I believe this is not in this particular patient. Though I would still ask him whether he was mindful of how many tablets he's taking. The other possibility is there any other drugs or any change of things which would have probably precipitated this issue? Something like amiodarone, which could be the reason, but amiodarone has already been stopped. and any other iodine containing substances, which is less likely. But probably something like any alternative medicine, like any of these homeopathy or Ayurvedic medicines, which are said to be containing heavy metals. Maybe consumption of over the counter these drugs due to any reason could have probably frustrated. I would try to ask him whether he took any of those things. So probably something like that. If other things are not there, then probably what I could think is the possibility of having a Graves' disease, where patients who have these Graves' disease who are hyperthyroid, or they may have phases of being hypothyroid and sometimes a hyperthyroid flare. Again, I'm not an expert in this field, but this is what I think of. I would be interested to know from Dr. Brinda about this. Probably that is another reason which could have frustrated his hyperthyroid issue. So reasons there are probably these things which come to my mind. Now, management for me in the clinical context of this patient, this is important, and we have to manage him quickly or stabilize his condition. So, first thing, drug of choice being beta blocker. He's already on carvedilol, but I believe in hyperthyroid state, non-selective beta blocker will be probably better, not only in controlling heart rate but also overall um, overall taking care of the other symptoms as well. So I would try to change his beta blocker from carvedilol to maybe propranolol to control his symptom status better. Uh, how do I diagnose? Interpreting thyroids, I'm not very much comfortable in interpreting thyroid function test, other than understanding about the TSH. I personally do not pay much attention to the free T3, free T4, and equally my understanding is limited. So again, this is an uncomfortable area for me. So I would definitely try to seek help from an endocrinology colleague and take their help. So I believe from the cardiology point of view, controlling his symptoms will be to give a higher doses of beta blocker, maybe increase carvedilol or probably change it to propranolol. I would prefer to change from carvedilol to propranolol, which may manage his symptoms, both his heart rates and subsequently blood pressure. Look at the cause. If there is any possibility of inflammation, like a thyroid flare, maybe a dose of steroid or something like that. And regarding the continuation, for me, first thing as a priority, I would definitely stop the thyroxine. Yeah, let the heat settle down. Once he is totally stable, then probably repeat a TSH maybe after 2-3 months, and then probably take a call. I would be hesitant to take this call personally. I would definitely rely on my endo colleague to help me get out of the issue, as I am not completely comfortable doing these things. And what are the other questions that are there, Anoop?
Pranit, I think you have answered most of the question. In fact, I will ask you a few questions and that can get the discussion going. So
Yeah.
you mentioned that you're going to ask endocrinologists' opinion about how to work this up and how to go forward with this. Is it something that you do every time when you have a patient with hypothyroidism who is taking supplement but has got deranged thyroid profile?
No. I would currently stop the drug if the patient is symptomatic, versus patients whom we normally see where they are hypothyroid and we find that their TSH levels is going down. There I take the liberty of adjusting the medicines myself. Like if the patient is otherwise asymptomatic and if his TSH falls to say about 1 and he's asymptomatic, I would try to reduce the dosage of thyroxine that he's taking on my own. Again, it is arbitrary, no science. There is not a situation where I completely stop thyroxine. I could only reduce it depending on the amount of the drop in TSH. So if the TSH is somewhere between about say like 1 or something, I would probably reduce his dose to something like a 50%. So if the patient was taking 100, I would suggest him to take 50 micrograms, repeat TSH again after 3 months. And a word of caution to meet an endocrinologist. There I get the confidence to make a change. But in this given situation, because the stakes are high, and equally because the patient is symptomatic, where the situation needs to be controlled efficiently and early, I would be, I'm not completely confident, so I would take the help of an endo colleague.
I see. So if I understand, Praneeth, the two aspects that you mentioned which helps your decision making, one is presence of hyperthyroid symptoms, and second is the underlying condition where what you are saying is the stakes become high. Is that what I'm reading?
Yes, absolutely.
Yeah. So in both of these situations, there you would escalate and ask for expert opinion, right?
Right.
Okay. Are you happy with the thyroid profile, like what you get, or do you typically do any other investigation, like the role of free T3 or free T4 or any imaging or anything of that sort, or any other investigation? Do you order personally, or you leave it all to the experts?
My level of understanding in this regard is limited. So I don't remember those cutoffs of T3, TS, free T3, free T4. The number that I look into is TSH, and I'm comfortable with that. Even if the patient gets the thyroid profile, I can't make a judgment or an assessment based on that. So I limit myself analyzing TSH, and something which needs attention beyond TSH, I would hand over that responsibility to my endocrinology colleague.
Thank you, Praneeth. I'll move on with the discussion. I'll ask Shankar sir to give his opinion, because this is as much of medicine as anything else. Shankar sir, a case like this comes, you can pretty much skip the cardiac point of view if you don't want to engage in that. But if a case like this comes, non-hypothyroid on supplementation, now comes in with deranged profile with some hyperthyroid feature, how do you take it? Shankar sir.
Good evening to all. This is a common situation we come across in our clinical practice. But here the levels are the very high, that low TSH and high T3 and T4. So this is a case of hyperthyroidism. So when we confront with a case of hyperthyroidism with this type of thyroid profile, we whether it is endogenous or exogenous. Exogenous means we give L-thyroxine or L-thyroxine out from outside, or endogenous overproduction of L-thyroxine with diseases like the autoimmune thyroiditis, the Hashimoto's, Hashimotoxicosis, this Graves' disease especially, and other conditions like the functional metastatic thyroid cancer, struma ovary, and thyroiditis, subacute thyroiditis. We mostly get cases with this profile. Then iodine-induced hyperthyroidism. These are all conditions where we get this type of picture, where the low TSH and increased T3 and T4. So here we have got a clear-cut history that patient has been taking Thyronorm 100 micrograms per day since a long time. So, but whenever the patient is on, especially, I think this might be a case of amiodarone-induced hypothyroidism, because amiodarone causes two types of AIT, that is autoimmune thyroiditis, where already if the patient has got a thyroid goiter or nodule, then he will develop it into thyrotoxicosis, hyperthyroidism. And when type 2 variety, where we get hypothyroidism. So amiodarone causes both hyperthyroidism and as well as hypothyroidism. So here I think because the patient has been on a long-term amiodarone, he might have developed hypothyroidism, that is autoimmune thyroiditis, and leading to hypothyroidism, amiodarone induced, and patient has been on L-thyroxine replacement therapy. But when patient is on replacement therapy, at least we should investigate that. We should, we should monitor the case frequently, because he may go into like this exogenous hyperthyroidism. So every at least 4 to 6 weeks to see the thyroid dysfunction. When the patient is on L-thyroxine, we should wait for 4 to 6 weeks. Then only we will see the thyroid profile changes. So here it is a definite case of exogenous hyperthyroidism because of long usage of this L-thyroxine replacement therapy without monitoring with the thyroid profiles, at least TSH. So then in this case, the low TSH and high T3 and T4. So with the symptoms, like symptoms of hyperthyroidism, loss of weight is there, heat intolerance, and the tremors, so jitteriness, and all these things, they go in favor of there is a hyperthyroidism of a long-standing duration. It's not a recent one. So that's why I give beta blockers, like especially as Dr. Praneeth alluded to, is a propranolol is an ideal one. In this case, we give in Ciplar or Inderol 10 milligram TID. Then I stop L-thyroxine, Thyronorm completely, and then I again do the thyroid profile after 4 to 6 weeks. Then I will see. Accordingly, I will put him on whether he needs L-thyroxine or not replacement therapy. That will be decided after 6 weeks of stoppage of this L-thyroxine. But meanwhile, for the symptoms, I give Inderol 10 milligram TID till symptoms subside. And after 6 weeks, after getting the thyroid profile report, accordingly, if the TSH is high and T3, T4 normal or T3, T4 are all low, then accordingly, I adjust the dosage of L-thyroxine. This is my approach in this case of exogenous hyperthyroidism.
Shankar sir, question for you. When these kind of cases come to your OPD, is there can a standard operating protocol be set where patients who have got parameters suggestive of hyperthyroid state, we should actively make an attempt to diagnose, to differentiate between exogenous versus endogenous, or you always give a trial assuming it is exogenous, and only if it doesn't work, then you look for more investigation? Like, what should be the general approach for these situations?
So that's why in the beginning only I told whether it is exogenous or endogenous. Here clear-cut history is there. That's why we are telling that it is a exogenous hyperthyroidism. But if it is endogenous hyperthyroidism, is the Graves' disease, for example. The more commonest cause of hyperthyroidism we come across in our clinical practice is a Graves' disease, the primary thyrotoxicosis, where we investigate. Patient will have the uniformly enlarged thyroid goiter will be there. There may be a toxic. I will come to that. Then uniformly enlarged thyroid goiter will be there. There may be orbitopathy may be there. There may be dermopathy. The pretibial myxedema will be there. So with that, we investigate further with the TSH receptor antibodies. If the TG antibodies or the TSH receptor antibodies are positive, then we clearly say that it is autoimmune hyperthyroidism. This is a Graves' disease, primary thyrotoxicosis. Then other conditions like subacute thyroiditis, most of the times we come across the postpartum period where the thyroid gland will be very tender to touch, soft and tender. And there also the T3, T4 will be elevated and the TSH will be lowered. So low TSH. So how to differentiate it from Graves' disease? And then we go for radioisotope scan or the radio isotope intake that will be there. There we the radio iodine I-131 we will be undetectable or low in case of subacute thyroiditis. But whereas in Graves' disease, it will be elevated. So with this radioactive iodine scan is essential. Radioactive iodine uptake that is essential to rule out whether it is a subacute thyroiditis or this Graves' disease. And other conditions also there, like struma ovary, then iodine-induced hyperthyroidism. There where we give iodine supplementations, and iodine, this L-thyroxine may be synthesized more, and we'll get this hyperthyroidism features. There also we differentiate it with the radioactive iodine uptake study. And one more is a thyroglobulin levels. The thyroglobulin levels will be low in exogenous hyperthyroidism. Also in functional metastatic thyroid cancer, struma ovary, thyroiditis, and iodine-induced hyperthyroidism. So if thyroid globulins are low and 24-hour so radioactive iodine uptake is also low, then it goes in favor of thyroiditis, struma ovary, and iodine-induced hyperthyroidism. Whereas there will be absence of goiter in case of exogenous hyperthyroidism. And the TG antibodies will be absent in case of exogenous hyperthyroidism. Am I clear?
Yes, sir. You are absolutely clear. You are absolutely clear. My follow-up question to that is the differentiating points that you have mentioned about the lab values and about the imaging. Is there a way for us non-endocrinologists for us to kind of pick up when we should be ordering or investigating these, or we should let endocrinologists do that? Basically, what I'm trying to understand is when these patients come to us who are already taking Thyronorm and who have deranged profile, should we be basing our investigation of choice based upon certain parameters, like what Praneeth said? If there are symptoms present, then he would escalate. Can you give us some tips that you use to escalate rather than simply saying, okay, let us stop the drug for now and see how things work?
Escalating regarding what?
Escalating regarding investigations or thyroid scan or radioactive scan that you mentioned.
Only,
is it,
only see here, there is a clear-cut history is there, and physical examination, all these things of findings are going in favor of hyperthyroidism. So exogenous or endogenous, it is a clear-cut case of exogenous because he has been taking Thyronorm since a long time. So that's why there is a low TSH and high T3 and T4. But whereas when we suspect there is a Graves' disease, see here also, as a clinician, I should suspect underlying other conditions of hyperthyroidism. Like, for example, there is a condition known as thyroid fractitia, where he might have taken a surface injection of L-thyroxine, larger doses are taken, the same picture will come in the thyroid profile. So we should suspect that also. But it is very difficult to differentiate it from exogenous hyperthyroidism. That is one more condition known as thyrotoxicosis factitia. So other conditions like the Graves' disease, toxic nodule, we investigate with the ultrasound whether any nodules are there. Then the same picture of hyperthyroidism, then we say that is a toxic nodular goiter. It may be a single nodule, it may be multinodular goiter. So Graves' disease, nodular goiter, multinodular goiter, metastatic thyroid cancer, summa ovoidea, thyroiditis, iodine-induced hyperthyroidism, all these will cause the endogenous hyperthyroidism. So
Thank you so much, sir.
Then we go for ultrasonography, then 24-hour radioiodine uptake study, then thyroglobulin. These three investigations we should order further along with the thyroglobulin antibodies, the TSH receptor antibodies. Then we can come to a clear conclusion whether we are dealing with the exogenous or endogenous. Amongst the endogenous, whether we are dealing with the subacute thyroiditis or functional metastatic or the Graves' disease. The further investigations in this case, if we are in doubt whether it is not due to exogenous hyperthyroidism, I investigate further with this radioiodine uptake for 24 hours, then thyroglobulin antibodies. With this, we can say that whether it is exogenous or endogenous.
Thank you so much, sir. At this point, I will invite Brinda for her thought process. And I also want to inform that the floor is open for discussion. So if any one of you have got any questions or comments, you can either unmute yourself, raise your hand, or write the question on the chat box, and I'll be happy to address that. So Brinda, you can take over the case. I know you know the case in quite detail. So if you could just give us your viewpoint about this particular case, and then some of the general questions that we have asked during the course of last 20-25 minutes of discussion. Brinda, all yours.
Hi, everyone. Good evening. So for this gentleman, with a history of hypothyroidism, a history of like amiodarone use, of course, back in time, we can go and analyze whether his hypothyroid, was secondary to amiodarone use, but now he's been off the medication for a while, and then, takes us by surprise with his current, symptomology with the, hyperthyroid kind of features. So honestly, I take my clue from the TSH level. If the TSH is frankly suppressed, like wherein, I'm talking about 0.001 or like undetectable, less than 0.01, I am usually already starting to think about, Graves' like picture or like, endogenous hyperthyroidism. So not so much like just relying on like, iatrogenic hyperthyroidism, like in this case. So, frankly suppressed TSH, elevated T4, T3 levels, I'm already starting to think about, some sort of endogenous hyperthyroidism picture here. We don't see this very frequently, but yes, absolutely, there are cases that we do see in clinical practice where, we see this switch between the hypo to the hyperthyroidism, and oftentimes we basically blame it on autoimmunity. So usually we're talking about these subset of patients who do have thyroid antibodies positive. In real world clinical practice, sometimes we may check, sometimes we may omit checking these antibodies because the TRAB antibodies, the TSH receptor antibodies, they are a little expensive test to order. So a lot of times we may not be checking frequently for these antibodies, but for a clinical case like this, there is a high likelihood that he had an autoimmune thyroid condition, which, essentially with the blocking antibodies, he did have hypothyroidism. And then subsequently, there was like a switch in a situation where, we're talking about that this patient likely harbored both stimulating antibodies as well as blocking antibodies. And so it was like more like, pushing the thyroid into a push-pull situation where it's like cycling up and down through these phases of hypo and hyper. So my thought would possibly go towards an autoimmune condition wherein he is switched from hypothyroidism to hyperthyroidism. And given that, he's frankly symptomatic, as Praneeth said, the stakes are high in such a complicated case. So for him, I would basically start thinking of how to, get this under control as soon as possible. So, like I said, if I take my clue from the current, the set of thyroid labs that he has, I would like to question him, about any recent intake, as Praneeth also mentioned, of any new drugs, sometimes any herbal medications, multivitamins, a very a recent, not so recent also, but like we're talking about the last 5 to 7 years that people have started recognizing biotin supplement, as an interfering factor when you interpret, thyroid hormone labs. So, I would definitely ask him if he's been taking a huge bunch of like biotin supplements. A lot of patients are taking it for, hair growth and hair loss. So I would ask, if he recently had any sort of like CT scan with contrast, any contrast history, amiodarone, any other drugs that he might have taken, alternative medications that might make me think, one pertinent history that I would also think about, as Shankar said, also mentioned a little bit, is thyroiditis, would be in the back of my mind. Although usually the TSH would not drop so low, but still I would consider this as my differential. So I would like to ask the patient whether he had like some sort of viral illness. Sometimes, we see patients don't remember this viral illness, like, in the, in the preceding few days. But, this could go back up to like even 2 to 4 weeks in history. So if you ask them, did you have like, any sort of fever, runny nose, like some sort of viral illness, say like the last month, because we've seen cases wherein actually, the post-viral like thyroiditis that ensues, like, presents like a few weeks later in terms of symptoms. So I would definitely ask him all of those symptoms, or all of that history. And then, coming to making a diagnosis, well, I mean, I do have established diagnosis right now that he has hyperthyroidism. Like I said, I purely don't say it is iatrogenic. So I'm thinking of some other underlying disorder. And then subsequent testing, whether I want to do a thyroid ultrasound or I want to send him for a radioactive iodine uptake. All of these things, honestly, in a more acute setting, like his clinical picture, like his clinical case, I would take it on a case-to-case basis. Like for him, I may not necessarily go towards any other further investigations. I would probably, first of all, like stop his levothyroxine because he's frankly hyperthyroid. TSH is undetectable. As far as starting any other medications at that point of time, that is when, I usually would like to trend their T4. So like if the patient presented with, T4 and T3 on their labs, like if they've not gotten a free T4 or a free T3, which, is considered to be a little bit more accurate in terms of giving the true clinical picture. So I would maybe request another T4 level in say 2 days or 3 days, because I know that, the drop in T4 could be anticipated on a daily basis as well if I was to check it. So, wherein I'm concerned about this patient deteriorating, I may actually request free T4 or a T4, T3 level in say 2 to 3 days even. And then based on the amount of improvement that I may see, having stopped the levothyroxine, I can take a decision to start basically any of the anti-thyroid drugs, like methimazole or PTU, or like even, make the decision of starting like glucocorticoids in this clinical situation. For the time being, like for this patient, I'd stop his thyroid medication, the levothyroxine, and because he's so symptomatic, I would put him on a beta blocker, something like propranolol, because propranolol, apart from being like a beta blocker to help cool down the adrenergic drive, but it also actually inhibits the T4 to T3 conversion, which is basically driving all the thyroid symptoms. So for a beta blocker of choice, I would go for propranolol. I'd probably give him a dose of somewhere close to maybe 20 milligrams 3 times a day. And then again, reassess him based on the symptoms in 2 to 3 days, along with the T4, T3 labs. Anoop.
So, Vrinda, question for you. So early on, you said the initial strategy would be to stop his thyroid medication and add beta blocker to it. At what point you put them on methimazole just purely based upon the labs or symptoms? That is number one. Number two, what makes you start steroids on these patients? Is it positivity of the antibodies? And number three, what is your threshold for admitting such patients?
Basically, starting any of the anti-thyroid drugs, I think this is wherein I would start, thinking like, is this something like to combine the first and the third question, that, is it some sort of like impending storm kind of a picture? Is the patient, like you said, cardiovascular, in terms of cardiovascular assessment, tachycardia, get an ECG, like, see if the patient is, in AFib or any other arrhythmias, a short of breath, thinking about like, symptoms like heart failure sort of a picture. Or, mentation is a very big thing when we try to basically differentiate between, thyroid storm, impending thyroid storm, that this patient needs to be admitted. So I think it's the decision making. Essentially, there is no clear-cut algorithm as to say, okay, this equals to, starting methimazole. But I think I would essentially see how symptomatic he is. Is he somebody that I would like to, just treat outpatient, or does he merit inpatient admission based on all these features? Does he have, like what I said, tachycardia, arrhythmias, a nausea, vomiting, does he appear to be acutely psychotic, delirious to me, and a fever, basically. So all of those features which we account for thyroid storm or impending thyroid storm. So then I would say that this patient needs admission, and we need to start all these anti-thyroid drugs and, glucocorticoids and everything else that we do basically for a treatment of thyroid storm. But for this patient, like coming back to the first question that you asked, whether to start, thionamide drugs or glucocorticoids, like I said, if the patient looks to me relatively okay, then I might do this, that stop the levothyroxine, give the beta blocker for sure to help at least, the patient cool down a little bit, and then reassess maybe in, 2 days. Like I said, it wouldn't be completely wrong, because if I'm already thinking that this patient with a history of like some autoimmune kind of a like picture in the background, then I may take the call that I'll just start you on something like methimazole today itself. Maybe not a high dose, because I'm also already stopping levothyroxine. So maybe roughly in the ballpark of say 5 to 10 milligrams per day, then I might initiate it. But most of the times I would first stop the levothyroxine, give the beta blocker, check a T4 or a free T4 in 2 to 3 days, and then take a call. When I see the patient back in 2 to 3 days and say if the free T4 or the T4 is say my rough ballpark is about 1.5 times above the upper limit of normal. So even if on my assessment on the second day, if I see that he's still kind of in that ballpark of 1.5 to say, then I would definitely start him on anti-thyroid drugs. Methimazole preferred if I'm still assessing the patient that this patient would be doing okay in an outpatient setting. But if I think the patient needs admission, then I'll start him on propylthiouracil. The decision to start glucocorticoids is when I'm not if we're not certain, or we haven't had the diagnosis clear cut that this is thyroiditis versus Graves like picture or a nodular autonomous thyroid nodule kind of a picture, then I would give the patient the benefit of doubt. Understanding that even hyperthyroid patients, with increased cortisol metabolism and all, they could actually be developing relative adrenal insufficiency as well. So if there are no contraindications to steroids, then I will start them, on glucocorticoids as well as an outpatient. Usually I do like a 1 week glucocorticoid therapy. We could start with like something like dexamethasone or prednisolone. And then I usually, if I do prednisone, I usually use the dose of 10 to 20 milligrams per day, and then gradually see, again, reassess, say, in a week with a repeat blood test, a T4 or a T3 level and a T3 level, and then assess them symptomatically, whether they are doing better or not. So oftentimes we make the diagnosis retrospectively if, the clear-cut diagnosis was not there between a thyroiditis-like picture versus autoimmune condition. Usually that is my thought process when treating these patients. Another good alternative, which I frequently do use, I do see that not a lot of people using it for treatment of hypothyroidism, is the cholestyramine, which is a bile acid sequestrant. It comes with the Coltrane powder under the name of Coltrane powder. I have, learned over time that this works acutely, like in a short period of time, it helps bring down the T4, T3 levels, in the patients, especially who are very symptomatic. So if I'm desiring to treat somebody outpatient, and I do understand that they are a little above than moderately, like mildly symptomatic, so I might initiate these people for 3 to 4 days on cholestyramine, 4 grams four times a day, like the powder 4 times a day. And then usually I do see that there is a good reduction for the most part, wherein gives me that window of time to decide whether this patient, I need to start them on methimazole or PTU or glucocorticoids. So sometimes I do use that in my practice.
Vrinda, few quick questions because we are running short of time. So number one is, what is the role of checking for thyroid tenderness? Is it something, of course, we all read it in the book. Does it help in decision making? The absence of it, the presence of it, I would think it would, but the absence of it.
Right. So if you are talking about like more acute thyroiditis like picture, then tenderness definitely helps. And that is like one key clinical giveaway that, yes, this is probably thyroiditis like picture. But, painless thyroiditis does exist. Mostly we see it like postpartum and all. The absence of it doesn't necessarily exclude thyroiditis as a diagnosis. And a lot of times in the acute phase, Sir also used that term, the Hashimoto's, wherein the Hashimoto, the hypothyroid patient flips into the hyperthyroid phase. So a lot of times actually patients present with painful glands. So the presence of it a tender thyroid will help me lean towards more thyroiditis like picture, but the absence of it doesn't necessarily mean thyroiditis is ruled out. And again, sometimes, although very rarely, we do see painful thyroid enlargement if it is more of a recent onset, just like the hypo to hyper conversion, but that happened in say a matter of few days, then patients may have a painful thyroid enlargement.
Can thyroiditis recur, like autoimmune thyroiditis that we're talking about?
It can. So as I mentioned, the autoimmune thyroiditis means that these antibodies are doing their game. So, whenever they want to switch on, they would. Whenever they want to switch off, they would. So many times we do see patients who actually, pass on from the hypothyroid phase to euthyroid phase. And I think, we do see a lot of patients roughly, say, I usually say about 5% of us might be harboring these thyroid antibodies, but we are all euthyroid walking around. But of course, all of these individuals are all at a higher risk of, developing frank thyroiditis, in future. So it could be an off and on, push and pull kind of a situation.
Last question is, and this is not pertaining to the case that we are discussing, but I did put in this case, this question as a part of discussion. Patients who are on thyroxine supplementation when they do have deranged thyroid levels, and when we are making adjustment to those dosing, are these dosing adjustments arbitrary, or is there some sort of algorithm or a thumb rule that we use in terms of how much dose should be increased or how much it should be decreased?
Again, no perfect blueprint for it, but I usually, or like what people do usually, is that they base their judgment on the thyroid profile. So suppose, let's say commonly we are not ordering T4 and T3, like say most of the patients are coming in with a TSH value. So if the TSH is between, say patient is a treated hypothyroid patient, but the TSH is between 5 and 10. So you would make an adjustment roughly to the order of say 12.5 to 25 micrograms upward dose, basically, on a daily basis. Again, we are also talking I didn't say it, but we also have to be mindful of the age of the patient. So usually elderly patients, I might go very slow, like make it 12.5 per day micrograms per day increase at a time. Younger patients will tolerate it easily. More than 10, TSH more than 10. Therein, I think, depending also on how symptomatic the patient is, how is he looking? Is he very puffy, complaining of symptoms which are classical hypothyroid? Then I may actually increase the dose even up to 50% for these patients at a time, but not more than 50% at a time. And if you have a free T4 or a T4 available to you, then that gives you a more realistic way of adjusting the dose of thyroid medication. So if the TSH is in the low one, the T4, is in the low 1/3 of the defined range, then I may increase the dose upwards of like 25 to 50 micrograms per day. But if they are in the ballpark of like say 0.5 times lower than what the free T4 or T4 should be, then I would be increasing the dose again in the lower order of 12.5 to 25 mics per day. Another percentage rule that a lot of people follow is 15 to 20% dose increase weekly for patients. And that 15 to 20% weekly dose could be calculated, again, keeping in mind older versus younger patient, cardiovascular disease, not cardiovascular disease, and all those things. So either a 15-20% increase per week, or base it on a daily basis. If you are basically looking at the TSH free T4 values, this is what I usually do.
The one more question, since you mentioned about weekly dosing, I often see differential dosing where patients are asked to take certain doses on certain days and certain doses on certain days. Is there a scientific basis to it, or they are done mostly because the intermediate dosings are not available?
No. I think because the half-life of T4 is 7 days. So makes it very easy to actually dose it weekly. So even weekly preparations are available, not in abundance, but there are, I think one of the companies does make a weekly dose of thyroid. So you can actually give a weekly, once a week dose also to the patient. So it kind of equilibrates over the 7 days. So usually it is the ease, like if a patient is taking, 100 micrograms per day, the bottles are, containing 120 tablets at a time. You call this patient after 6 weeks, the patients will usually say, madam, I have 2 months of medication remaining. So you can easily like play around with the doses and calculate it on a weekly basis for these patients.
I'm just reading a few questions from the chat box. The question from Sapna, I think this question is answered over the discussion, the role of testing antibodies and when to test these antibodies. I think Sapna, this question has been answered. Praneeth asks lab to lab variation in thyroid profile. So Vrinda, do you see a lot of lab variation in thyroid profile or they're mostly correct?
I do see a lot of variation lab to lab. And, we don't have standardization of labs in India. So it is a difficult task, to read through all these labs. But I think that is where, if there is a high degree of suspicion that, the numbers and the clinical picture isn't matching, you just ask them to repeat it at a more, like a reputed lab essentially for the patient. Especially the TSH assays, they are so much prone to this variation. So I think for whatever we have, I think if there is a suspicion, just repeat the test.
One question is asked is numbers to remember for TSH, T3 and T4. I think Praneeth, that question is answered because there are, I believe, because so much of lab variability is there. I don't think there will be a standard number that one can remember. We will have to look at the reference values. The other question which is asked is, Vrinda, do you remember offhand which is the company which offers weekly dose for thyroid supplement?
If I remember, but I would have to double check. I think it is Thyrox. But I would have to double check. I would double check.
Thank you, Vrinda. At this point, I will ask Somaraju sir for his comments about today's case and the discussion. Somaraju sir.
Good evening, everybody. Thank you, Anoop. It's a very exhausting and very nice discussion. I'll just come to this patient. My impression about this patient is this patient was given amiodarone for some time, and to me it was amiodarone-induced hypothyroidism. And some of the patients, amiodarone-induced hypothyroidism, the hypothyroidism is reversible, and the thyroid function may become normal later after some time. And then at that time, when the 100 microgram dose which was started was continued forever, and that was the cause for his present situation. So not to be aware of this reversibility of a thyroid function with amiodarone-induced hypothyroidism and not to be monitoring was the cause for the patient's present problem. I also want to know, with this degree of iatrogenic hyperthyroidism, what is the clinical status of the patient? Heart failure, etc. LV function. Can you tell me, Anoop?
Yes, sir. So clinically, he actually happened, to my surprise, doing reasonably well, particularly with the background that he had.
That's enough information. That also shows the doubt about the original evaluation of the patient. Thank you.
Sir, one question which I want to ask you, there was this discussion about in hyperthyroid patient who are reasonably maintained on a cardioselective drug like carvedilol. And we know that in hyperthyroid, propranolol or non-selective beta blockers are the drug of choice. Would you actively go and change the drug or would you continue carvedilol? Is there a justification for that?
If the patient has a symptomatic because of hyperthyroid status related to it, and it's worthwhile trying propranolol and stopping carvedilol. But if this patient, as you say, this patient is doing otherwise well, this patient is symptomatic because of hyperthyroid status, the symptoms of hyperthyroidism are dominating the heart rate, etc., worthwhile doing it under observation carefully and not as an outpatient. Thank you.
The reason why I asked, sir, is because whenever these heart failure patients who have been otherwise quite stabilized on a cardioselective beta blocker, I always worry of changing their beta blockers, even in the setting where, even when there is a parallel clinical setting which requires or where the drug of choice is a non-selective beta blocker. One of the common scenarios that we see is esophageal varices in liver cirrhosis, where propranolol is the drug of choice. But if these patients are very well stabilized on cardioselective, who have established heart failure, it becomes quite uncomfortable to change at that point of time.
No, carvedilol is the patient symptom, as you said, the patient is stable. There's no need to change carvedilol and continue it. Carvedilol is also a reasonably good choice for even esophageal varices. Thank you.
Thank you so much, sir. If there is any other question, maybe 1 more minute we can take. If no questions, then I will. Shankar, sir.
One more thing to the viewers. Whenever we give thyronorm, there is a thyroxine, certain drugs should not be combined with this. It should be taken especially in the early morning on empty stomach. And for 1 hour, we should not consume anything, either tea, coffee, or any breakfast or anything. And one more thing is along with the thyronorm or thyroxine, the calcium supplements or iron supplements should not be given along with the L-thyroxine. And one more thing is these PPIs, the proton pump inhibitors like pantoprazole, omeprazole, these esomeprazole should not be combined with the L-thyroxine. At least there should be a gap of minimum 2 hours. But I prefer to give sometimes the PPIs at bedtime. There also the acid will be suppressed, or the thyronorm can be given on empty stomach in the early morning, and this PPI can be given half an hour before breakfast, so that at least 2 hours gap should be there. At least 1 hour gap should be there before we consume anything. For 1 hour, we should not consume even tea, coffee, breakfast, anything. It should be preferably taken in the early morning on empty stomach. The absorption of the drug will be proper enough, and it should not be moist, and it should not be kept on the refrigerator. Sometimes patients, they keep these bottles in the sun so that the efficacy will go off. So these precautions should be taken whenever patients consume this L-thyroxine.
Thank you so much, sir. Praneeth, your closing comments for today's discussion?
I think one of the common situations and an unusual complication or an unusual situation that we have discussed today, I think it is probably worth noting that any patient with hypothyroidism who is on thyroxine replacement, this monitoring is necessary, because there is some negligence in even monitoring, where people tend to come back to follow up and they ignore and keep taking the same thing. So it can lead to this one of the serious complications, which can sometimes lead to serious issues. So the point of monitoring, and once in a while when the situation arises, then knowing about this situation and how to deal, and when to take help from your colleagues, is something which is extremely important. And I think the role of beta blockers, stopping thyroxine, and probably adjuncting therapy has been well highlighted. I think it's more of an educated information, and this is something like that you keep it at the back of your mind. It may not be quite common, but if needed, I think having a knowledge will definitely make you more comfortable dealing with this patient. I think it's a good topic that we discussed today.
Thank you, Praneeth, and thank you all of you for attending today's session. We are significantly out of our designated time. I'll close the session at this point, and I thank all of you for attending. We will meet again next Wednesday with a new topic. Thank you all. Good night.